Welcome back. Now we will start with our second session, that is the instrument design. In that we will discuss all the instruments, because laparoscopy is instrument dependent surgery, and before using the instrument we should learn it, that how it works. Some people are saying that laparoscopy is a byproduct of medical engineering. It is something which is imposed by engineers over the doctor. Like engineers, they were using the camera, fiber optic, the telescopes, and they gave the idea to the surgeon that it can be used. So that's why instrument design we will discuss. Now before discussing the instrument design, we should learn that laparoscopy, if you want to become a good laparoscopic surgeon, then there are three important disciplines which we have to keep in mind. One is ergonomics, another is task analysis, and third is psychoengineering of the minimal access surgery. The laparoscopic surgery stands over these three important pillars. One is ergonomics, second is task analysis, and third is psychoengineering of the minimal access surgery. Now first is, what is ergonomics? Can anybody tell me the definition of ergonomics?
It is the position of your body according to the environment. So when you work, everything in relaxation regarding the position of shoulders, the position of the patients, monitors.
Very good. Means ergonomic is interface between man and machine to improve the task performance. It is the interface between man and machine to improve task performance. Anywhere when you are using the machine, you must learn the interface through which you can communicate with the machine. Like suppose we are driving the car, we never know how car works, how the petrol is moving the wheel. That we don't know, because we are not engineer. We don't know how the car is running. But we must know that what is the ergonomics. Means interface, like where is the clutch, where is the gear, it is automatic transmission or it is manual transmission. It is having how many gears, where is the indicator, where is wiper, where is the horn. This is interface. Without knowing that, you cannot drive a car. In minimal access surgery, a good surgeon and bad surgeon depends upon if he is good in ergonomics or not. Even if you are very experienced, but you don't know how to fix the problem with the ergonomics, then you cannot perform better. Your task execution will be wrong. When you are performing any surgery and suppose some problem happens, suppose some bleeding has started, then we are seeing, oh, that surgeon has cut the uterine artery, or he has damaged the CBD, or he has injured the ureter, or he has injured the bowel. But is it sufficient to see like that? It is not. We should see that why he did this complication. And if you will see now carefully, most of the complication of the minimal access surgery is due to wrong ergonomics. Wrong ergonomics means his port were wrong. He was swording, he was overshooting, he was doing ipsilateral, he was having bad manipulation angle, bad azimuth angle, bad elevation angle. What is that? That I will discuss. All those things I will discuss. When a car accident happens in India, there will be a news that one car and one bus or truck was clashed together and so many people were injured. That's all. But it is not the same if that accident happens in US They don't see as an accident. They will see the angle why this accident happens. How can we prevent it next time? And if suppose 2-3 accident happens at the same place, then they will change everything there. They will change the speed limit of the road. They will change the signage. They will see that is it a sharp turn, or there is a bad divider, or there is a bad lighting. What's the problem? And then they will correct it. So next time accident will not happen. If a car company comes, then they will inspect their car and they will see that why this driver was killed. If you go to the big showroom of the Rolls-Royce or expensive car, BMW, Mercedes, in the big showroom in the state or in Canada or some of the premier showroom of the UK, they put big accident pictures, photographs. They will show you this was the impact from 200 feet, this was impact in 180 km/h speed. This you can see the position and the condition of the car, but no one was killed. Everybody was safe. If someone died during the accident, then they want to hide this news, and they want to see that what was the problem with the safety features of the car, where the airbag didn't work, how the impact was going on the passenger or driver. So we should improve the safety feature. If you are on an expensive car and after accident if you are getting injury, that means car is not safe and people will not buy. So exactly same way in minimal access surgery, if something goes wrong, we should not see as a complication. We should see as an ergonomical point. Ergonomics is responsible. And unfortunately, ergonomics is very less discussed in the minimal access surgery. Few examples I will give you, then you will understand how much it is important. Just like when you enter into a car, first thing what you are doing, that you are adjusting your seat in such a way that you should be in comfortable position and your legs should comfortably reach to the pedals like the brake and the clutch. And then once you see that it is I am comfortable, then you will switch on the car. Exactly same way, once we enter to the operation theatre, first thing we should do is to adjust the OT table height. And OT table height should be adjusted in such a way that the handle of the instrument should be at the level of the elbow. Handle of the instrument should be at the level of the elbow. If it is little up, you have to do abduction of the arm and your performance has to deteriorate. If it is I am holding the instrument like that and my arms are abducted, within 5 to 10 minutes I will start fatigue there and my performance will be affected. Exactly same way, if it is low, you have to bend and then also your performance is affected. For any work, if you want to do in your day-to-day life, you have the better task performance if your workstation is at the level of the elbow. Like this laptop, if it is at this level, I can type better, but if I will put here, my speed will deteriorate. Even if you are writing, your hand is at the level of your elbow. When you are playing keyboard, your hand should be at the level of elbow. Exactly same is rule of laparoscopy. Ideally it should be 0.49 into the height of the surgeon. If surgeon is 1 meter tall, 100 centimeter tall, then the OT table should be 49 centimeter. It doesn't matter even if the patient is big or patient is small or patient is thin or patient is obese, it doesn't matter, because instrument is going inside the abdomen. So it depends upon the OT table height. obesity is in the abdominal wall. That will be crossed by the instrument. So this is one ergonomical example. If someone is struggling, there may be a simple reason his OT table is not properly adjusted. Most of the operation table is made for the open surgery, but ideally laparoscopic operation table should go up to 24 centimeters from the floor. And that is especially now if you have to order, you always take the OT table which can go up to 24 centimeters only from the floor. If it is for orthopedic surgery or if it is for the open surgery, it may not be appropriate for your laparoscopic surgery. Another ergonomical example is that coaxial alignment. Coaxial alignment means that eye of the surgeon, target of dissection and the center of the monitor should be in the same line. Like suppose this is appendix and you want to perform surgery. Then you will stand there. This is target of dissection and monitor should be here. So all the three, eye of the surgeon, target of dissection and center of the monitor should be in the same line. If it is in the same line, that is known as coaxial. If there is more than 15-degree head tilt, then your performance will immediately deteriorate more than 25%. Head tilt will create the traction over the sternocleidoid muscle, and then the nerve endings will get stimulated and your performance has to deteriorate. Nobody can stop it. Just if you are typing a simple, you are writing a letter, and if you will keep the book from where you are copying on another angle, your handwriting will be bad. Your lines will start going in wrong direction. So for any task performance, not only laparoscopy, coaxial alignment is required. Exactly same, this is ergonomics. So suppose this is appendicectomy I have to perform, and I am putting monitor here, I am standing there, then I have to see like this, and then my performance has to be affected. Then this is ergonomics. Then the distance from the monitor should be 5 times to the diagonal length to the monitor screen. Suppose you are using 21-inch monitor, then you have to stand 105 inch away from the monitor. Monitor diameter, the size of the monitor is calculated by the diagonal length. Diagonal length means one corner to other corner. And if diagonal length is 21 inch, then you will stand 105 inch. 21 inch. If it is 14 inch, then you will stand 70 inch away from the monitor. If you are nearer, your performance will be bad. If you are more than 5 times to the diagonal length of the monitor screen, then also your performance will be bad. Now the question is why it is necessary? Why, how can we say that it is important? From center of the monitor, you should be 5 times to the diagonal length. Now question is why? Why 5 times? Because if you want to see anything better, if you want to see anything good, then that object should fall over your macula of the retina. In retina, the central part is macula. That has a high concentration of cones. Cones are responsible for color perception, resolution and acuity of the image. And on the periphery what we have? Rods. Rods are only seeing the black and whites, and they don't see the precision. The rods are not good. So ideally our image should form over the macula. If the object is too near, then it will go to the rods. Suppose I am seeing this entire laptop from this distance, then it will not remain on the macula, it will go to the rod because image is too big for the macula. And if I am far away, it is too small for macula. So only object will not come, periphery will also come. And then also there will be different depth. Suppose from here I am seeing this monitor, this is far away. And then I am not seeing only a screen. What I am seeing HUD also, I am seeing these tables also, I am seeing ceiling also, I am seeing wall also. So there are different depths. And for each depth I will try to make a mean focal length. And then my sharpness of the image will be lost. And I cannot perform the surgery better. To understand it is a distance. Just I will give you a simple example of the movie theater, cinema hall. In movie, when you go to see the movie, if you have paid the maximum money, they give you the seat which is 5 times to the diagonal length of the screen. If you measure the screen and then you measure the length of the hall, 1, 2, 3, 4, 5, your seat is here. Then you see only a screen, you are enjoying maximum. If you will pay little less money, they will give you far back, maximum back. Now what will be problem from there? That you are not only seeing the screen, you are seeing head of the other people also. And you are seeing some of the wall also. Because your screen is smaller for the macula. Because you are more than 5 times away. If you have paid very less money, they will give you just in front of the screen. Now you cannot accommodate the entire screen, even your eyeball. You have to see this side there, that side there. Isn't it? You have to tilt your neck. If you are seeing actor, you are missing actor. So that way your performance will be bad, poor. Exactly same way, anything you want to do better and high precision, better acuity, it should be 5 times to the diagonal length of the monitor screen. And that's why this is one ergonomics which we should keep in mind. There are 2 types of ergonomics. One is universal ergonomics, another is specific ergonomics. Universal ergonomics means this ergonomics is valid for all the specialization and all the surgery. Like even if you are surgeon, you are gynecologist, you are urologist, it doesn't matter. OT table height has to be adjusted like that. Coaxial alignment has to be respected. The 5 times to the diagonal length is must. But there are few specific ergonomics that depends upon that particular surgery. Like the port position, position of the first surgeon, position of the second surgeon, position of the camera person, position of the patient, position of the entire OT, like setup. And those all ergonomics I will discuss. I am just giving you few example of the universal ergonomics. And we have seen few, like one is OT table height, another is coaxial alignment, third is the distance of the monitor from our eye, fourth ergonomical point, you can take one example, that your level of the screen from your eye should be 10 to 20 degrees down. Because resting eye always see down. We never see up. When you are resting, like you are resting, then you see down. Are you seeing up? If you do like that for 5 minutes, you will get headache. Your eyeball, because oculomotor muscle in the resting position, oculomotor muscle will keep the eyeball little down. Isn't it? That's why when we go to the cinema hall, if you have paid more, then your seat is little up. Your height is little more. The screen is little down. So that you are resting position, you are seeing like that. If you are not paid, then you are seeing up. Because your screen is above. So always you should adjust. This trolley has a adjustable screws there. You should adjust in a way. That's why nowadays OR1 system and ceiling mounted monitors are recommended, so that you can adjust the height according to your requirement, and it should be 10 to 20 degree down in the height of the surgeon. Another example of the ergonomics is OT light. जैसा एक टेलीस्कोप और एक दो इंस्ट्रूमेंट ले आओ. OT light should be 20 lux. If the OT light is very bright, you will get artifacts, and that will create optical illusions. Just like here, this is a monitor and there is a lot of light in this room. You can see there are some light seen on the screen. Right now monitor is switched off, but once you will start doing surgery, these creates artifacts, and that add extra optical illusions. So if you want to see better, you should decrease the light, and ideally it should be 20 lux. Exactly same way, you should always take care that your manipulation angle should be 60 degrees. What is manipulation angle? Manipulation angle is the angle between two working instruments. This is manipulation angle. This is one working instrument, this is another working instrument. Right now, what is this angle? 180. This is 0 or 10, 30, 60. This is 60. Remember, whatever you do in your day-to-day life, you have the better task performance if your manipulation angle is 60 degree. If your manipulation angle is not 60 degree, you cannot perform anything. Even when you are writing right now, your both the hands are at angle of 60 degree. Can you see that? If you are playing keyboard or if you are typing, your both the hands are, this angle is how much? It is 60 degree. And 60 degree manipulation angle is required. The drummers, when they play drum, both the sticks are at 60 degree. The female, when you are knitting sweater or pullover, both the forks are at 60 degree. If I will tell you to knit it at 180 degree, can you take one wind also? Won't be possible. You cannot take the wind. You cannot. It will pierce. It will sword. So for ideal task performance, always your manipulation angle is 60 degree. In open surgery, it doesn't matter. Anytime I can decrease, anytime I can increase. But in laparoscopy, it depends upon where your port was put. If your port is wrong, your manipulation angle throughout the surgery is wrong. Isn't it? Suppose this is fundus of the uterus, and I will put the port just on the top two ports here. Now this manipulation angle is fixed throughout the surgery. I cannot increase or decrease. Or if I will port at both the anterior superior iliac spine on either side. Now this is fixed. Unless until I will sacrifice that port, I will put another. If I want to use it, now my manipulation angle is fixed. And throughout the surgery I am crying. Throughout the surgery I am struggling. And why this was? Because I was not knowing what is the principle of the port position. Port position in most of the book, unfortunately, is not described. And most of the people, they remember the port position. Like for hysterectomy, one port in the umbilicus, one port 3 cm lateral to the anterior superior iliac spine, 3 cm medial and above, and one port right iliac fossa, one port left. This is not correct. Because port position of a uterus of a 8 cm length and uterus of a 24 cm length want to be same. Your ovarian cyst of 4 cm, ovarian cyst of 20 cm cannot have the same port position. And our body pathology is never always fixed. It keep on changing the position due to adhesion, due to some of the extra feature, due to some myoma. It may be posterior wall, it may be anterior wall, it may be broad ligament. And we cannot perform all the surgery with the same port position. For that, there should be some principle of ergonomics. and that is known as baseball diamond concept of port position. That I will discuss, and you all will learn that principle. There are some calculations, some angles, some geometrical lines, and if you draw those lines, you will get crystal clear port position, and that will be ergonomically so intuitive, so attractive that throughout the surgery you will enjoy. Nobody can claim that your ports are wrong. And once you will learn the baseball diamond concept of port position, even the gynecologist can put the port for urologist, and urologist can put the port for surgeon. Because what is surgery? Surgery is dissection and tissue approximation. This is surgery. It doesn't matter which specialization you are doing only these two things. You are dissecting and again approximating. In surgery there is nothing else. And whatever your specialization is, the minimal access surgery is same. It doesn't matter if you want to learn a driving, it doesn't matter how you use it. You can use your driving skill to kidnap one person also, and you can use it to get a long drive and enjoy also, or you can use it as a commercial to earn money, or you can use in the race to just win the game. But the skill is same. Exactly same way, once you have the minimal access surgical skill, then you can implement in your specialization. But the basic principle of the port position never varies. Basic principle of dissection, suturing, knotting, tissue approximation, tissue retrieval, these are same for every specialization. So, baseball diamond concept is ergonomics, and that's why this is the manipulation angle 60 degree. Exactly same way elevation angle. What is elevation angle? Elevation angle is the angle between the instrument and the body of the patient. This is elevation angle. If elevation angle, suppose this is uterus, and I will put one port just above the uterus. What is elevation angle? 90 degree. In relation to the body of the patient, it is 90 degree. If I will go 18 centimeter away, it will become 30 degree. If this manipulation angle, elevation angle, then 90 degree, can you make a omelette also? You cannot make it. How can you turn it? If you try to move it, you will burn yourself. It will jump on your body with the elevation angle 90 degree. But if it is 30 degree, you can turn it. This side, turn it that side. Elevation angle also depends upon your baseball diamond concept of port position. If your port is wrong throughout the surgery, elevation angle will be same. It cannot be varied unless until you bring the target nearer. If this is the instrument, if target is nearer, elevation angle is increasing. If target is away, elevation angle is decreasing. But target will be fixed. Sometimes the gynecologist has this privilege that by using anteversion and contralateral traction you can move your target, but not up to the extent you want, and surgeon can never do that. Surgeon cannot bring the hernia into the midline to perform the surgery. Hernia will be there, and you have to put the port according to your target. If your port is wrong, your elevation angle is wrong, your manipulation angle is wrong. Then comes the azimuth angle. Azimuth, A-Z-I-M-U-T-H. Azimuth angle is the angle between the telescope and instrument. That should be ideally 30 degree. Azimuth angle should be 30 degree. But in any circumstances, it should not be less than 15. And in any circumstances, it should not be more than 45. If it is less than 15, I have to struggle. There is no way. I am struggling throughout the surgery because my azimuth angle was wrong. Exactly same way, if it is more than 45 degree, you have to struggle. There will be loss of depth Q. There are two things. One is depth perception, another is depth cue. Depth perception is a stereoscopic vision, and depth cues are hints about the depth. There are many types of depth cue in laparoscopic surgery, like linear parallax, motion parallax, relative size, aerial gradient, shadow. These are our depth cue. I will discuss in detail once I will discuss the optical instruments and the port position. At that time I will show you all those depth cue. And if you have a wrong port, your depth cue will be wrong. And throughout the surgery you are struggling. You don't know why you are struggling, but your shadow is wrong, your linear parallax is wrong, your motion parallax is wrong. This is ergonomics. If you want to become a good laparoscopic surgeon, then you should learn ergonomics. And scientifically, everything has explanation. There is nothing in laparoscopy which doesn't have explanation. If you are not able to tie a knot in intracorporeal suturing, that doesn't mean you are a bad surgeon. That means you are not adequately trained. Someone has not given you the vision how it works. Once you understand the thing how it works, then your eye is open completely. That's why in medicine, even it is not required, but we have been taught how these drugs are working. So if you are using one antibiotic, then in your brain one artificial imagination is forming. that this antibiotic will go and will block the DNA, or it will rupture the cell membrane, or it is acting like that. Because and then you get the confidence that this we should do, it will do like that. Exactly same way in minimal access surgery, it's a physics, and it's a lot of things are there which you should learn, and then your fundamentals will be strong. One of the important is ergonomics, that is interface between man and machine. These are only few examples I have given. Throughout the course, we will keep on discussing ergonomics of every surgery, ergonomics of suturing, ergonomics of knotting, ergonomics of extracorporeal, intracorporeal, dissection. Then we will learn different type of energy sources, how it works, how bipolar works, how monopolar works, how harmonic works, how ligation works, what is the difference between active electrode monitoring system, how something is cutting, coagulation, blend, and the different wattage of the energy, why it is required in some less and some more. And then you know why my vessel could not be sealed, that you should know. Sometime when you are sealing the uterine artery, the bleeding stops, sometime not. Why? That we should understand. What should be the traction, what should be the amount of tissue which you should hold, which type of tissue needs how much wattage, and how to catch it, how to tie it. This is the meaning of ergonomics. If you want to become a good laparoscopic surgeon, you should develop a good sound ergonomical principle in your brain. Another important pillar of the minimal access surgery is task analysis. What is task analysis? Task analysis is sequential steps of the component of any task, is known as task analysis. Sequential steps wise description of any task is known as task analysis. Just like any task, I am not talking only about laparoscopy. Just like suppose I will request you to make a cup of tea for me. How you will make? Can you explain it, please? Yes?
Yes. First I have to enter the kitchen.
Yes.
And then I start the gas.
Yes.
And put a bowl over there.
Very good.
And put some water.
Very good.
First I have to boil up to the boiling temperature.
Okay.
Then put tea.
Okay.
And sugar.
Okay.
Milk.
Okay.
And then wait up to the makes good in flavor.
Very good.
And color.
Okay. Color and flavor you want to make good. with the okay, then you will distribute in the cup and you will give it to me. He has tried his best, but there were 4 mistakes. 4 mistakes were there. I will tell you what are the mistakes. First mistake, that first he should arrange all the things which is ingredients which is necessary to, but that I will excuse because it is supposed, yes, he is a man, not only that, he is expecting that because I have given this task, so everything should be ready. So okay, let us forget it. Second mistake what he did, that he didn't ask how much sugar I want. Maybe I am diabetic, I will not take sugar, isn't it? Another mistake, you should never add sugar together with the tea leaves and the milk. Remember, as soon as you will add the sugar in the boiling water together with the tea leaves and milk, a specific gravity of the water will increase. And you will never get the color and flavor which you were stressing. Remember, if the water alone is with the tea leaves, then osmolar difference is more, isn't it? Because water is thin and tea leaves is thick, and from the tea leaves permeability of the flavor and color will occur. But if you will add the sugar at the same time, then a specific gravity of water is increased, and then it will no more osmosis up to the extent which you want, and then color will not be good, flavor will not be good. Another, it should not reach up to the 100-degree boiling point. The tea leaves should be added at 60-degree centigrade temperature. Do you know there is one chef who has written 500-page book how to make tea? This is 500-page book to make a tea. Although in that book he has explained the history of tea also, who has invented tea, who was the king who first used the tea, how it was distributed, and different type of tea. In different country, tea has a different flavor. In Libya, they have different tea. Turkey, they have different tea. In India, tea means a lot of sugar, which you have added first. And in many countries, they don't take much sugar. It is very hard with a lot of tea leaves. So the idea is that the sequential components of the task is important. Any task which we do, it has 2 components. One is procedural, another is executional. Any task has 2 components. One is procedural, another is executional. What you have explained about the tea, you have explained only procedural steps. Like I will boil the water. Boiling the water is a procedure. But it has a lot of sub-steps, that is intra-steps. How you will execute that? 2 people can boil the water 2 ways. One will switch on the stove, he will put the kettle and then running for the water here and there. He will bring the water. By the time kettle is red hot, he will put the water, he will burn himself. Isn't it? Another one, he will put the water first in the kettle, then he will switch it on, and then he will transfer the kettle with the water. The exactly same way, success of the laparoscopic surgery depends upon the task analysis. You want to do hysterectomy. There are 5 steps. Procedural. One is access technique. Second is the adnexal dissection. Third is the separation of the bladder and the anterior and posterior leaf. Fourth is the uterine artery. And the fifth is the, either if you are doing vaginal, the vaginal part. If you are doing the TLH, then you will do the colpotomy. Exactly, cholecystectomy 5 steps are there. What are those steps? The first step is access. Second is exposure of the Colles triangle. Third is dissection of the cystic pedicle. Fourth is separation of the gallbladder from the gallbladder bed. And fifth is extraction of the gallbladder out. Procedural steps, nobody does the mistake. Everybody knows procedures. That is not a problem. 5 procedures, everybody will do the same. Nobody can dissect the gallbladder before suturing or clipping the cystic artery and duct unless until you are doing fundus first. Isn't it? But the problem starts with the executional steps. Executional steps, suppose you are holding the cystic pedicle, which peritoneum should be dissected first, posterior peritoneum or anterior peritoneum? Which direction you should strip the peritoneum, from below up or from above down? This makes the difference. Sequential steps of the task analysis is such important that this makes a surgeon good or surgeon bad. If you are putting A, B, C, D, E, F, G, H, then B should always be after A and C should be before D. If you are changing the sequences, accident is waiting to happen. And scientific sequential steps of the surgery should be programmed in your brain just like a movies. The things which you like a lot, you are remembering each and every movement of those things which you like. And we try to think again and again up to the extent that it is completely imprinted in your brain because you like. If you like your boyfriend or girlfriend, each and every movement of it you are rethinking because you want to make it a movie in your brain, short, that is because it is pleasant. In laparoscopic surgery, if exactly same way, the executional steps of the surgery should be implanted up to the extent that each and every small component of the procedure should be arranged in a sequential fashion. And then nobody can stop you becoming a good laparoscopic surgeon. Problem starts because our sequence we don't know. And then we start in open surgery, it doesn't matter. Because the assistant who is standing on the opposite side of the table, he is taking a lot of your work just by giving verbal command. And two brains are simultaneously working together. If you are not pushing the bowel, he will push it. You want him to get everything exposed, red carpet, he is making a red carpet for you. By putting all the traction, by lifting the uterus, by giving the adnexa, and then you just work spontaneously. But remember, whenever you are having some limitation, your task performance needs to be very much refined. Just like we have eye, so suppose I have to go from here to airport, isn't problem. You can go to the stair, you can go to the road, you will ask taxi, they will take you to the airport. But if suppose I am blind, then I have to go, then my task performance is many times requirement is increased. I have to learn how many steps I have to go to find out a stair. How many steps are on the stair? How I will know I am on the main road or not? How I will know this is taxi or not? With the taxi I am inside, I don't know where taxi people is taking me. Exactly same way, minimal access surgery, it's a surgery over image, and you don't have the verbal command to ask the assistant to catch this bleeder. If something goes wrong, you have to manage your own. So a small error in the task analysis will create a big problem for you because we have the limitations, and wherever you have the limitation, task analysis should be completely perfect. In college cystectomy there are 5 procedural steps and 51 executional steps. 51 steps are there. That is scientifically analyzed. 1, 2, 3, 4, 5, 49, 50, 51. If any chain is disturbed and task is one after another, if you are, then you will mess your surgery. So try to memorize the sequential steps of the surgery in your brain up to the point of absolute certainty. and then problem will not happen. Your surgery will be successful. Third is engineering and psychology. In laparoscopy, you have to develop yourself as an engineer, because you are trapped with so many electronic parts. You have 6 electronic equipment together. The camera is there, the monitor is there, the insufflator is there, the energy sources is there, suction irrigation is there, and different type of light sources are there. Now sometimes if the picture is not coming good, we ask nurse, she will come, poor nurse, she will say, okay, this is, I will try to fix. This is not good. Do you know, camera, when I will demonstrate you camera, it will take 2 hours time. The camera has aperture control, shutter speed, fibroscopic fillers, then the automatic gain control, then the different type of focusing, then the white balancing. For different surgery, different type of setting is required. That poor nurse, she has not been educated, and she is just given the information by the instrument company, just to how switch off and on. And if you don't know your machine, you cannot use it. If you are buying a very expensive iPhone 5, iPhone 4, and you don't know what are those buttons, then you don't have right to keep this. Give it to someone else. Better to use only 3,000 rupees mobile, which will be good to talk. You can use it more efficiently. Otherwise, you will be trapped with so many buttons. But if you know that how can I use the GPRS here, how can I use the MMS here, how can I record the videos, how can I update to the YouTube, then it is good for you. Exactly same way, more expensive the camera, more feature it has. Like the high definition 3-chip cameras, I will show you all those. It has a lot of varieties, a lot of possibilities. But we need to learn it. The light insufflator has the quadromanometric indicators. It is not a foolish box. It has a 4 important indicators: preset pressure, actual pressure, flow rate, total amount of gas used. That is known as quadromanometric indicator. 4 important pressure indicators, and the relation between these 4 makes a dramatically difference. You have to learn. And if you know quadromanometric indicator, which I will explain each and every component, within 5 seconds you will know where your gas is going. It is going in vessel, it is going in preperitoneal, it is going in bowel, it is going into the muscle, it is going subcutaneous, or it is going in a renal cavity. It has all the information. It has a microprocessor. That microprocessor gives you the different type of alarms and the amount of the actual pressure and total amount of gas used. That has a correlation. There is a graph, and if you understand that, immediately you will know that where your gas is going. Take it out and put it there. There are different color temperature in different light source. Halogen, LED, xenon, they have a different color temperature. This is our duty to learn that which we should use in which surgery. If you are doing hysteroscopy, what should be the setting of the camera? If I am doing laparoscopy, what should be the setting? So without learning those engineering aspects, it is dangerous to perform surgery. Dangerous in the sense, if something goes wrong, we don't know how to fix it. There are fuses inside, there are a lot of control, there are a lot of standby. You have a standby bulb, you have a standby circuit. And troubleshooting, we should know what is going wrong and how to troubleshoot. This is engineering component. Psychological component is also important. Rasmussen, he was a very great psychological study he has done for surgeons. He had published many articles, psychosomatic aspects of the minimal access surgery, and according to him that laparoscopic surgery is not good for certain personality who is actually very aggressive, and the type A plus, angry people, anxious people, they are not fit for laparoscopic procedures. In his study, he has seen that people who has a good extracurricular activities, they were good in laparoscopy, like who play sports, they have interest about the gadgets, electronic devices, good in software, good in computer, good in painting, good in printing, good in music, they were good. Some people are not technically perfect for minimal access surgery. Why? Because the people who blame others, they cannot perform surgery better. Because it needs to be done in a very peaceful and a creative mind. For them, open surgery is good. If you see some of the professors, if you remember, the older time, very senior professors, some of the people were very aggressive and personality and angry people. If he is coming from the road, you will like to leave it, you will like to go from the other. You will not try to face him. Because you are afraid, what he will tell you don't know. If you are assisting him, you are very much afraid. And before he asks, you do everything. If you will ask seizure and accidentally you will give artificial, you will throw it. What is this? What you are giving? Where you have done? You don't know anything. Right now, what is seizure is required? And you are not giving proper traction. How can I cut? Have you assisted it before? You say no, sir. Then that means he is forcing you to perform and give him a red carpet. Means you don't want to struggle. He want to only give the verbal command so that his things will be done perfectly. The problem starts in laparoscopy. In laparoscopy, there is no role of assistant. Assistant can only help you to show the telescope. Your left hand is your assistant, your right hand is your surgeon. And if you are struggling, then the same colleagues, same juniors, everybody is witnessing your skill. This is the problem. Witnessing, they are seeing and they will smile if some bleeding starts. Then he will say he was thinking that he is very smart, see here what he is doing. What he is doing. Then they feel like frustrated and they stop the surgery. And then they will not let the junior also to do. Because in their opinion, if they cannot do after so much experience, that this is something which cannot be given to the junior people. But remember, the World Association of Laparoscopic Surgeons has one slogan that if you want to make a community of minimal access surgery, catch them young. If you want to get a gold medal in the Olympic, you will catch which age group? Young. You will catch the people who is 12-year-old, 8-year-old, and you will train them. There is a possibility that you will get the gold medal. But if I will catch a 80-year-old person and train him to develop a minimal access surgical skill, it will be difficult, virtually impossible. Laparoscopy is a skill, and a skill execution is better if you are young. But young means, as a surgeon, even if you are 40, 50, you are young. It is not like, but the thing is, the idea is that earlier you will start, better your performance will be there. Late you will start, it will be more practice you have to do. More time you have to devote. So, actually it is not correct. There was one study done, in that it is already proved that the experience of the open surgery is not required to learn laparoscopy. You will be surprised, in the Europe and the USA, some of the surgeons, they don't have any experience of doing open cholecystectomy. They have never done. Directly they have started laparoscopic course. Because how they will do? Nobody is ready to get it done. So they are not learning open. They directly start with the laparoscopy. And no problem. And remember, anatomy of the body was never that much good before laparoscopy. Laparoscopy has given such a good anatomical picture to understand. In old time we were reading the Gray's Anatomy and the diagram or sketches. What is this? You have never seen, you can never orient yourself. Isn't it? But now everything is on the videos and each and every anatomy is changed. Now the laparoscopic anatomy should be there ideally in the curriculum. In the first year or second year MBBS. So the idea is that you have to be dependent upon yourself only. You should never be dependent upon the other. If you want to dependent upon the other, laparoscopy you cannot do. You have to take all the responsibility on your own. You should also learn how to hold the camera properly. Because if your assistant is not holding it properly and you are expecting better, then you will train him that please hold this way so that I can see it better. Otherwise, only shouting will not help. We have to help him to find it and to catch it better. So this is a difference in the people who are very loyal, humble, very gentle to their team. They develop their skill because once you perform surgery, your nurse, your other assistant, they also want that your surgery should be successful.